You know what? I'm going to start, and I'll project my voice, and I will speak slowly, and we'll get started here, and then you'll be able to follow along on the slides. If you look at the title in the program, the original title is False Promise: From Do No Harm to Distributive Justice in Medical Ethics and Why We're All Sicker as the Result. And I sent that title in a few months ago, and as I was working on the paper, I realized that that's kind of a negative title, so I decided to come speak to the same issues in a more positive way. So my new title is Renewed Trust: Finding Our Way Back from Distributive Justice to Do No Harm in Medical Ethics. My thesis is that distributive justice has come to crowd out all the other ethical values in our everyday clinical practice, and it happens in an automatic, unconscious way. And unfortunately, the dominance of distributive justice is undermining the trust in our relationships with our patients. I think we can restore trust with our patients by making a concerted effort to make do no harm the central principle of ethical practice. And finally, clinical experience tells us that outcomes improve when we have relationships of trust with our patients. So this isn't just hypothetical. There's actual clinical outcomes that result, and they're better when we get ourselves in the right ethical alignment. So let's start with a case, and this is a case from my practice. I have the patient's permission to use it. I've modified some of the details to disguise the identity. So I have this patient, George, and he's 55 years old, and he has developed gastroparesis after 45 years of type 1 diabetes. Gastroparesis is a condition in which the gut slows down. It's a sort of neuropathy of the gut. Because George's gut cannot absorb iron, it's been necessary to treat intermittent bouts of severe anemia with IV iron infusions. At a recent visit, George tells me that he's been feeling cold, tired, and down, and I'm treating him for depression, but when he's feeling cold, in addition to feeling tired and down, that's a telltale symptom of anemia, and I've known him for a long time, so I know these symptoms. So I refer him to his hematologist, who I'm going to call Dr. Winston. Now, for extra credit, does anybody know where I got the name Winston? Okay, this is an obscure allusion. Winston was the protagonist of 1984. So at our next visit, after George saw his hematologist, I was taken aback to learn that he wasn't going to get his iron infusion. Why? Well, turns out he's on Medicare because he's disabled, and his hemoglobin was measured at 10.8, and Medicare won't reimburse for iron infusions unless the hemoglobin level is 10. So George has been paying me out of pocket in my direct pay practice, so I figure shouldn't be a problem. If Medicare is not going to cover it, then he can pay for the iron infusion himself. It's a stretch for him, but it's a treatment that really works for him. So I'm going to leave off here and let you think about this case, and we'll work our way back around to it. Now, this is the outline of my talk. I'm going to briefly review the place of distributive justice in ethical methodology. I'm also going to review the origin of distributive justice in the history of medical ethics. We're going to talk about the clinical implications of making distributive justice by default the predominant value in medical ethics. And finally, we'll talk about how to restore trust with our patients. So here's an overview of ethical methodology. Now, this part of the talk is going to get a little dense, but I think it's important to understand the terminology. The terminology gets thrown around quite a bit, and I think it's a real problem to let experts interpret ethics for physicians. I think we really need to take back charge as physicians. We need to take back charge of interpreting our own codes of medical ethics for clinical practice. So to that end, I'm going to be giving you some ethical theory. So what's the purpose of medical ethics? I'm not going to read this whole slide, But I think medical ethics is really at the heart of it a method of clinical problem solving. These are not abstract philosophical theories. This is about clinical care. I think at its best, medical ethics and codes of ethics provide an articulation of the physician's duties to her patients, and it's a point of reference for conscience. That's at its best. I think at its worst, we can think about medical ethics as a set of rules that can be enforced to protect patients from doctors. Okay, let's review three major approaches to ethics that I think are complementary, and these are popular trains of thought in the field of medical ethics. There's a couple of guys, Beecham and Childress, who've written a very influential book about medical ethics. It's pretty much the standard text when ethics is taught these days. I think they're up to about a 7th edition. And they advocate for a principle-based approach to ethics. A principle is a statement of some fundamental and universal moral truth that's expressed as an action guide. So Beecham and Childress elaborate 4 major principles. One is respect for autonomy, which means that we respect the decision-making capacity of autonomous persons. The second is non-maleficence, which translated is do no harm. And do no harm means we avoid causing harm. We can't necessarily prevent the harm that's already there in the illness, but we're trying to avoid causing harms ourselves with our interventions. Beneficence means that you try to provide benefit for patients and you balance it against the risk. So we're trying to offer treatments that actually do some good. And finally, Beecham and Childress say that justice should be one of the principles of medical ethics, and they define justice as fairness in the distribution of benefits and risks. So let me give you a couple of clinical examples to illustrate these principles in practice. I show respect for the autonomy of my patients by explaining to them different treatment options and explaining the pros and cons. If I was going to be paternalistic, I would review all that in my mind, and then I would pick the one that I thought was best for my patient. But instead of doing it that way, I review with the patient my thinking process, and I give the patient a chance to weigh in with which risks he's more afraid of, which values are important to him. That's respect for autonomy. I'll give you a clinical example of do no harm. I had a patient who I treated for many years on lithium, and it was a very effective treatment for him for major depression, but he was getting to be older. He was about 65 years old, and lithium can cause renal insufficiency and renal failure. It's rare, but it can cause it, and the risk goes up as you get older. And this was a man who wasn't really willing to tolerate any risk. So I had him discontinue the lithium because I was afraid we'd get to the point as he got older that it would become very difficult to protect his kidneys. It was kind of a rough transition to a new mood stabilizing drug, but that was a do no harm kind of clinical intervention. And beneficence, I'll give you an example of that. I'm a psychoanalytic therapist, and I go pretty light on the prescribing, but when I have a patient with obsessive compulsive disorder, I'm not going to treat them with just psychotherapy. I'm going to put them on or try to persuade them to take a serotonin reuptake inhibitor. So I will promote that with my patients with obsessive compulsive disorder because I think it's an effective treatment. And I'm not just going to do the psychotherapy that I do with a lot of my patients. So those are a few clinical examples of those principles in action. Now, Beecham and Childress articulate these 4 principles, but where do they come from? Now, I'm going to quote from Beecham. The morality shared by, and please follow along, the morality shared by all serious persons in all societies is not a morality, it is simply morality. It is universal because it contains ethical precepts wherever morality is found. Now, I don't know about you, but I find this definition to be pretty vague and circular. So who are these 2 guys to tell us what the universal morality is? So I'm looking for some different kind of anchor. So to me, it seems like if we want to anchor our principles in something, let's anchor it in the clinical situation. And I submit to you that principles that are valid for medical ethics are always compatible with and never at odds with good clinical practice. So let's ground our principles in the actual clinical experience and not have it be some abstract philosophical theory. Okay, another approach to medical ethics is virtue ethics, and this is complementary to principle-based ethics. Edmund Pellegrino and David Thomasma are my favorite authors on this topic. So virtue ethics focuses on the physician as a moral agent in a relationship of trust with her patient. The idea is that a physician who is habitually disposed toward the good and the right can be trusted by her patients, and the virtuous physician diligently strives to make the right attitude toward patients automatic and reflexive. So the idea here is that if you just have principles and you don't have good moral character interpreting those principles, then the interpretation of the principles can get pretty distorted. On the other hand, if you just have good moral character, but you don't have any ideas or any grounding or any linking to anything universal, then you're in danger of being unfocused in your practice and getting subjective. And then finally, the third approach, major approach to ethics is known as casuistry. And I call casuistry case-based ethics. And the idea here is that moral acts and moral agents are judged on the basis of the effect on the patient. So in clinical medicine, diagnostic reasoning is based on taxonomy, paradigm cases, and analogy. And clinical inferences are always open to revision in light of fresh evidence. The idea here is that the problem with principles is that they can feel kind of rigid and inflexible. And when you're actually working with patients, situations change. So you want to be able to amend what you're doing in light of new clinical evidence. So casuists, just like physicians, use ethical paradigm cases from which they work their way to less understood and the more disputed type of cases. So you take the kind of case that you feel pretty sure about and you think you know what to do ethically, and you reason by analogy to the case where you perceive an ethical dilemma and you're not quite so sure about what to do. Now here's a really important point about casuistry. The hard cases, the marginal cases, the ambiguous cases really leave room for conscientious difference of opinion. So there can be more than one right ethical answer. So the idea is that it's a good idea to have principles. We need some kind of grounding in some kind of understanding of what we're doing that we can share with our colleagues and with our patients. That's principles. We want to promote good moral character, and we want to have a methodology that's consistent for looking at cases. So there's three legs to this ethical methodology. So now that I've given you all that, oops, I seem to have jumped. Okay. All right. There we go. That was the slide I was looking for. Let's dig into this whole word justice in a little more detail. Now, if you'll remember, Beecham and Childress said that justice in medical ethics is fairness in the distributions of risks and benefits. Well, it turns out justice is a little more complicated than that. And our old friend Thomas Aquinas divided justice into two major parts. One part is commutative justice, and the other part is distributive justice. So distributive justice is what you're going to be hearing a lot about today in this talk. So commutative justice is the kind of justice that applies in a one-on-one relationship. And the idea is that it's fair for us to give others what they're due, and it's also important that we don't take from other people what is rightly theirs. And when you have a one-on-one relationship, it's pretty clear to define what our duties are, and it seems pretty plausible that if somebody transgresses, you can figure out what the right kind of compensation would be. Now, with distributive justice, this is an idea that applies to the relationship between an individual and the community, or the individual and society. It's not a two-person relationship anymore. And this gets tricky, because if we think advantages and disadvantages ought to be distributed fairly, well, what's the duty of the community to an individual? What is that really? And when things go wrong, and when one individual doesn't get what the community supposedly owes to them, well, then who's responsible? Where does the compensation come from? So distributive justice for us as physicians, I think, is hard to get our minds around, because we're accustomed to thinking about two-person relationships. Notice that Beecham and Childress conflate justice with distributive justice, and that's only part of the whole picture. Now, John Rawls is a popular ethicist, and he wrote about social justice. So that's a different word than distributive justice. Social justice, broadly speaking, is the study of the ways in which major social institutions distribute two things. One thing is the fundamental rights and duties. So when you're trying to distribute rights and duties, you're talking about due process and the structures that society sets up for due process. When you're talking about distributing things that are rationally regarded as advantages or disadvantages, that's distributive justice. So social justice has, in my view, has two components. We might also point out that everyday informal social practice complements the formal institutional mechanisms. Now, in discourse today about medical practice, social justice gets conflated with distributive justice. And I think that's a problem, because let's not forget due process. And I think a lot of times nowadays in our pursuit of distributive justice, due process gets trampled on. So I think we want to be clear in our minds as physicians about the difference between due process and distributive justice, and we also want to be clear in our minds about the difference between justice broadly speaking and the more narrow problem of distributive justice. Now let's say something a little bit about charity. With social justice or distributive justice, we tend to locate the distribution of advantages and disadvantages. We leave that up to the major social institutions. And when we do that in medicine, our natural impulse to altruism is effectively blunted and outsourced. So charity, on the other hand, is altruism in the context of a one-on-one relationship. So if you really care about people and you want to do good for them, are you going to pursue that through theories of social justice? And in that case, you really have to rely on other people to carry it out? Or are you going to enact your altruism in a one-on-one context, which is charity? And I submit to you that charitable care is a really good thing, and we shouldn't get so preoccupied with social justice that we lose sight of that. The giving of charitable care aligns the physician in a stance of virtuous practice. And with charity, the distribution of benefits can be tailored precisely to the needs of the individual, and that's different from the kind of distribution of benefits by social institutions. Those tend to be one-size-fits-all approaches. The other nice thing about charity is fraud is impossible. If you're giving away your care to a person freely, they're your patient and you're giving them free care, they might pull the wool over your eyes. They might not be as financially needy as they led you to believe. You might get duped every now and again, but that's not fraud. It's being taken advantage of, perhaps, at a personal level, but that's different than defrauding a benefit program like Medicaid or Medicare, and there's a whole lot of different implications. Okay, now here's really the central part of my talk. The patient-physician relationship is a two-person, one-on-one relationship. And commutative justice is really the dimension of justice that can be appropriately applied to a dyadic relationship. We ought to give our patients what they are due, and what they are due is a relationship of trust. They ought to be able to trust us. We also ought not to take from our patients what belongs to them, and by that I mean we don't exploit our patients for personal gain. That's being fair to our patients. So in a one-on-one relationship, a relationship of trust, that's justice. In discourse today about medical practice and medical ethics, the concept of distributive justice is being inappropriately extrapolated into this dyadic relationship between patient and physician. And this creates role confusion and false perception of competing ethical values. Bioethicists like Beecham and Childress tell us that we have to balance distributive justice against do no harm, beneficence, and respect for autonomy. Sometimes these principles are going to come into conflict, and the bioethicists tell us, well, sometimes do no harm and respect for autonomy is going to have to give way to distributive justice. And I say this is a false choice. We don't balance do no harm, respect for autonomy, and beneficence against distributive justice. Distributive justice doesn't belong in there. It's in a different place. It doesn't belong in our minds. So it's not the role of a physician to remedy social inequity. It's our role to treat the disease and suffering that might result from social inequity, but it's not our role to resolve the social inequity directly. So the methods used by social institutions to distribute and withhold benefits are incompatible with the relationships of a trusting one-on-one relationship. The methodologies used by social institutions are the methodologies used by social institutions, but those aren't methods, I submit to you. Those aren't methods that we should be using in medical practice with our own patients. Now, I'm not saying here that we have to throw out distributive justice. I'm not saying that we shouldn't have some kind of conversation in our community about how to mend in social inequities, how to make things fair, how to help people out of positions of disadvantage. We should have those discussions, and there might be a place for social institutions in resolving those problems, although they're really inefficient. But there still might be a place for social institutions. But all of that should be happening outside the office and outside the bedside. That's really the central argument here, is that we should put it in another place. Let's not bring it into our relationships with our patients. So we started, I'm going to time check. I think we started at 9. Yep. Are we sticking with the original 50 minutes?
Yep.
Okay. And finally, I think in ethical theory and conversation about ethics, we don't talk enough about the role of the unconscious mind. So psychic determinism is the idea that our unconscious minds make all of our decisions, and our conscious minds invent rationalizations after the fact. Now, I think that's an overstatement, and it's not quite that extreme, but I think it's useful to keep that idea in mind. So most accounts of medical ethics do not systematically examine the impact of culture and the patient's unconscious mind on the physician's unconscious mind. Our patients influence our unconscious minds by repeatedly telling us stories about themselves until we believe those stories. And once we believe patients' negative stories about themselves, we as physicians start to close off possibilities for patients because we believe the stories they tell us after a while. Now, politicians and commercial vendors influence our unconscious minds as physicians by repeatedly telling us stories about ourselves as doctors until we start to believe those stories and we act in accordance with them. More on that later. External regulation can contain sometimes the unconscious impulses that lead to bad or ineffective practice by a few physicians, but unfortunately, when you have too much external regulation, we degrade the ability of all physicians to exercise their consciences because motivation becomes externally motivated rather than internally motivated. Systems of care and public policy that center on distributive justice rely heavily on third-party financial incentives to influence the clinical decision-making of physicians. So these incentives work primarily by appealing to the physician's unconscious motivations, thus bypassing moral reasoning. So if you believe that distributive justice is a valid moral principle, and if the main method used by proponents of distributive justice in medical practice is to go straight to our unconscious minds and bypass our ethical reasoning, is that a good idea? So there's people out there working day and night to get into your unconscious mind, and you need to be ready for them. Okay. I'm noticing our time, and we're going to skip over the history of medical ethics and get right to that case. So I'm going to skip past a few slides. I will make this paper available if anybody wants it. So there's some density to it. Yes?
Yeah, I'm in the process of uploading it to the website, and I'll send the link out to the LC leadership group.
Great. Thanks, Charlotte. So let's get back to this case. So we've got George. I've been talking to you about principles of medical ethics, and George is still out there suffering from untreated anemia. So I called Dr. Winston to talk to him about this case. And I said, hey, George is willing to pay for this IV iron infusion out of pocket. But Dr. Winston refuses that suggestion, and he's rather annoyed with me. He participates in Medicare, and when you participate in Medicare, you're prohibited from billing patients out of pocket for covered services determined to be not medically necessary, and you can't appeal this kind of thing. So Dr. Winston wouldn't even consider the IV infusion, even though it worked in the past. I suggested to George that he seek out a hematologist who had opted out of Medicare, but there isn't one in rural Vermont, and George didn't want to travel for that. So George went with untreated anemia for months until finally Dr. Winston treated him with a painful intramuscular iron injections instead of the IV, which would have been better. So we'll do a little bit of audience participation here. So how many of you are bothered by this? Sometimes I think, go ahead and I think in our culture we take these things, maybe not the people in this room, but a lot of people take these things as pretty routine. Oh, well, shucks, the insurance doesn't cover it. I guess we can't do it. But this deeply disturbed me. So, how does distributive justice play out in this case? How in the world can Dr. Winston's clinical decision be justified ethically? Well, this Medicare regulation purports to distribute care only to the patients who really need it, in the service of conserving limited resources for all. So I think in this case, the only way Dr. Winston's decision can be considered ethical is to recognize that the principle of distributive justice is paramount over his other ethical duties to his patient. So I think this ranking of ethical responsibilities was unconscious, as evidenced by the fact that Dr. Winston never even considered a way to arrange needed care for his patient. such as a referral to a colleague who opted out of Medicare. I don't think Dr. Winston is really thinking about distributive justice in his conscious mind. I think in his conscious mind, he's complying with the law. He's complying with the regulation. But really, he's really identifying with this whole distributive justice cost containment thing at a very deep level. So for Dr. Winston, a denial of reimbursement is synonymous with a prohibition on care. So Dr. Winston is unconsciously identifying as an agent of society rather than a clinical agent for George. So in this case, distributive justice supersedes beneficence. If Dr. Winston had put beneficence first, he would have found a way for George to get that IV iron infusion. In this case, distributive justice supersedes respect for patient autonomy. If Dr. Winston had really honored that principle, he would have given George a choice and he would have made the referral. George's laboratory data is not confidential to his detriment. Confidentiality is one aspect of respect for patient autonomy. Confidentiality means the patient gets to decide what happens with her personal information. So in this case, patient autonomy gives way to distributive justice and its insatiable demand for data to enforce its system of rationing care. And in this case of George, distributive justice supersedes fidelity to trust. Dr. Winston was acting as an agent of the state rather than an agent for George's best clinical interests. And you can see when we put distributive justice at the center, you get a worse clinical outcome. Let's look at accountable care organizations. We looked at a case, now let's take it to the system level. So the Centers for Medicare and Medicaid Services define accountable care organizations as groups of doctors, hospitals, and other healthcare providers who join together voluntarily to give coordinated high-quality care to their Medicare patients. Now they have lots of fancy language about the payment mechanisms. One-sided shared savings, two-sided shared savings, bundled, partial capitation, global payments, global risk. Lots of jargon. What are they hiding with all this jargon? Basically, the whole idea of an accountable care organization is that hospitals and doctors risk financial penalty if they fail to reduce costs or meet quality standards. How are the accountable care organizations actually doing? Well, the metrics, you can read the slide, the metrics that they're using to measure quality of care are really hard to interpret. So there is not solid evidence that they're improving quality of care, and they're definitely not reining in the costs. After all this elaborate structure, so far, it's not working. Now, the problem with measuring clinical outcomes is that the systems of care that are based on distributive justice, they measure population metrics rather than in the kind of individual outcomes that measure to patients. The ACOs are measuring hospital readmission. Well, hospital readmission sometimes means that's a good thing for the patient to get readmitted and treated. Sometimes it means he wasn't treated well in the first place. So it doesn't mean much as far as, well, it's hard to interpret what it means to the patient. Patients can sicken and die while they're waiting for care, or they can get better. Patients who are offered excessive care because they didn't wait long enough to get better spontaneously still have a chance to evaluate the risk of treatment and avoid it. Thus, I think longer waits for care are apt to produce worse clinical outcomes. Or to put it differently, the risk of getting too much care is less and can be mitigated compared to the risk of waiting too long for care. So I think measuring wait times for appointments is a good quality metric to be measuring when we're evaluating payment mechanisms and systems of care. Now, systems of care based on distributive justice control the metrics, and they tend not to publicly report wait times. I guess we can figure out what that means if they're not reporting it. Independent direct pay practices tend to have shorter wait times than accountable care organizations. One of the problems for advocates of system of care based on do no harm and fidelity to trust is that we tend to lack the data to prove that we're getting better clinical outcomes. And I think we could do a better job coming up with the right kind of metrics to be tracking. Okay. So, the ethics of accountable care organizations. If the central feature of the accountable care organization is to put hospitals and doctors at financial risk, then the central ethical principle is distributive justice. The physician who balances the best clinical interests of patients against the imperative of stewarding scarce resources has become a double agent, and that's really not compatible with the virtue of being a trustworthy physician. Okay, so how do we as physicians lose their minds? I want you to pay attention to this part. So politically motivated public policymakers and medical corporations use a variety of tactics to get doctors to unconsciously identify with the third-party interests rather than the interests of patients. And here's some of the tactics. Repeatedly telling doctors stories about themselves and their profession. For example, the system is broken. Medicine is an industry. Fee-for-service doctors are driven by volume rather than value. These are the stories that are out there. They're trying to brainwash us. The politicians and commercial vendors repeat catchphrases, buzzwords, and slogans. Healthcare is a human right. Provider, evidence-based care. And finally, physician leaders are recruited to buy into distributive justice, usually enabled by handsome bonuses, and then they influence their employee clinicians to identify with them. So doctors tend not to like remote managed care reviewers, and they'll fight with managed care reviewers who are trying to withhold reimbursement for care. But if it's your own medical director, you know him personally, and you tend to like him better than that remote managed care reviewer. So physicians who face financial risk based on clinical outcomes favor distributive justice over ethical values in an unconscious, automatic way. The physician is thinking in his conscious mind that it's evidence-based practice, following practice guidelines, aiming for good metrics, or bending the cost curve. So when physicians speak favorably of distributive justice, note, they nearly always refer to it as social justice, and they speak of it at the level of public policy. How often have you ever heard an advocate for social justice in medicine say, this is how I bring social justice into my clinical decision-making with my individual patients? I've never heard a proponent of social justice talk about it that way at that level. They're always talking about it at the abstract, big level. They don't bring it down to the level of the encounter with the patient. And that means what you're doing with the patient, if you buy into all of this, it's unconscious. Systems of care and systems of public policy that set physicians up to act as agents of distributive justice don't tell patients and the public at large that this is happening. And finally, when the decision is made to let distributive justice into the equation of clinical decision-making, it becomes much less of a choice of competing values. It's not like you're thinking this through. Hey, I'm working for this accountable care organization, and I got this challenging case. Am I going to put distributive justice first, or am I going to put respect for autonomy first? Physicians aren't thinking about ethics at that level. Distributive justice is the automatic, unconscious default position. So, let me provide a contrast and a positive note. Let me tell you about my direct pay psychiatric practice. I observe do no harm by selecting the treatments that are least likely to cause side effects, free of pressure from third-party financial incentives that would drive me toward the cheaper, more harmful treatments. I observe beneficence by offering treatments that are most likely to provide benefit, unimpeded by financial incentives attached to compliance with practice guidelines. I also observed respect for autonomy by guarding confidentiality. I saw Twyla come in, and it's great that she came in right before I'm mentioning confidentiality. I think she'll be telling you about that. So I don't link to any electronic databases, and that's a stance of showing respect for patient autonomy. I observed respect for autonomy by telling the patient at the time of the first phone call what my fee is going to be. I also observed respect for autonomy by taking the time to obtain full informed consent, free of pressure from third-party payers to limit my time with patients. Really getting informed consent, really talking things through with patients takes time It's not a filling out a form, and direct pay practice gives you that kind of time. I observe commutative justice by giving my patients what they're due, which is fidelity to trust, unimpeded by any obligation to third parties. Distributive justice is never observed in my practice, but I'm quite happy to help my patients conserve their personal resources by offering them efficient care at fees much lower than the fees quoted by the teaching hospital. I don't ever have a waiting list in my practice, and that's an indirect marker of better clinical outcomes. I also get more face-to-face time with my patients compared to the ACO practice. That's going to produce better clinical outcomes. So I do set up my practice model in order to avoid hassle. I want to have more face-to-face time with my patients so I can provide better quality care. And I want to make more per hour so I can spend more time with my family. All those are true motivations. But my practice is also designed to cultivate the stance of being trustworthy to my patients. I'm only working for my patient. I'm not working for anyone else. So, distributive justice does not belong in clinical practice, I submit to you. The choice to rank distributive justice ahead of other ethical values in clinical medicine is a false choice, because distributive justice is relevant to the relationship between an individual and society. Distributive justice is not relevant to a relationship between two people, a patient and a physician. And I suggest to you that the ethical physician will want to set up an internal moral firewall to keep distributive justice out of the clinical decision making. So here's how you do it. How do we settle these competing ethical values? There's 4 principles. There's a virtuous stance we want to cultivate. We have to think about case examples and reason them all through. So I propose these tests for evaluating the validity of ethical theory. The empirical test. Depending on what ethical value is given precedence, what clinical outcome will result for the individual patient. Don't weigh ethical values in the abstract. Always try to make it into a case. The second test is the transparency test. Could you disclose your method of weighing ethical values to your patient? So if you're working in an ACO, can you imagine saying to your patient directly, you know what, that treatment would benefit you, but I'm going to withhold that treatment because I'm not going to get the bonus this year. Can you say that to a patient? I guess if you can say that to a patient with a straight face, then go ahead and participate in the accountable care organization. But if you can't say that, you might want to reconsider working there. How do we evaluate the moral quality of public policy for systems of care? Does the public policy or system of care predictably cause harm to some patients? If so, then the policy or system is ethically flawed in its design. Causing clinical harm is different than failing to correct social inequity, because correcting social inequity is not the aim of medicine. So, one last slide. The moral firewall. Preserve and promote your ethical mind. Repeatedly tell your own stories about yourself and our profession, such as, the practice of medicine ennobles the practitioner. Medicine is a profession, not just a business. Don't repeat the catchphrases and buzzwords and slogans promoted by political and commercial interests. Substitute your own. Hippocratic medicine, physician, free market medicine. And finally, become a physician leader and be a good role model for your colleagues in ethical practice that's centered on do no harm and fidelity to trust. And I'll end there.
Yay, thank you. Thank you.